Hi, everybody. Thank you all so much for joining us here at the New York Times Center and online. There is a lot of energy in this room. There's a lot of energy in New York City right now. I think you may all know that. I'm Jonathan Prince. I'm on the leadership team at Abridge, and I shouldn't touch my mic like that. This, of course, is Shiv Rao. He's the CEO and co-founder of Abridge. We're going to get right to it, but I want to give you just a quick rundown of what we're going to do over the next 70 minutes or so. So in a moment, Shiv and I are going to have a conversation. And if you know anything about Abridge, you won't be surprised that we're going to have a conversation. If you're just learning about Abridge now, you'll hear a lot more about the conversation very soon. There'll be a little news in that conversation. We've had a little news already today. And then after that, Shiv is going to lead a demo that's packed with new capabilities, all designed with a single purpose: to restore the humanity to healthcare and help clinicians get back to being clinicians full time. And then we've got 3 panels. Leaders from Johns Hopkins and Aetna will join us to talk about AI-enabled value-based care. Leaders from Emory and Cigna will join us to talk about closing the gap from care to reconciliation. And then we've got a really special conversation with Kimberly Powell from NVIDIA, who leads healthcare there, about what we're working on with them together. So we're going to get right into it. When you talk to doctors today, when you're rounding on the weekends, when you're sitting with doctors who use Abridge, what do you hear over and over?
Yeah, I hear a refrain. I think all of us clinicians feel the same way. We wish we had more time. We wish we had time to spend with our patients unpacking all of their medical histories, unpacking their health-related goals, and then actually spending time with them to chart a path towards those goals. We have so many competing priorities, so many compliance boxes to check, so much care to coordinate, so many guidelines to keep up with. It's been absolutely incredible to recognize that tech is helping, AI is helping. It's been incredibly humbling to hear that Abridge is helping, but there's so much more work to do. More than 4 in 10 clinicians last year reported to the AMA that they're burning out. More than a third said they're considering leaving the profession, and burnout is the #1 reason.
Right, so let's stay there for a second. Talk about a little why that's happening. It's not that clinicians are having trouble keeping up with the medicine or the science or how to do new procedures, right? What's going on?
No, clinicians love learning. We are lifelong learners. We talk about the practice of medicine. We don't purport to say that we can perfect it. And when you're in front of a patient and you're already calculating the note you owe, you're thinking about the prior auth you got to get ahead of, you're thinking about the consultants you need to call. That's not medicine. It's, I think, what medicine became when we strapped the entire billing and compliance machine onto the backs of the people giving care. Clinicians, at the end of the day, we're stitching together workflows that really span not just the patient, but all the different stakeholders. It's providers, it's payers, it's life sciences even. And you're thinking about every quality measure. You're thinking about every payer transaction. You're thinking about every research database, every registry, every prior authorization. And you're needing to know how to use certain words in a certain order in order to get full credit for the care that you're delivering. And that information, that context, it's not something you can engineer easily across any one system. It really lives across any number of different systems. And really, reality, it probably lives in a lot of people's heads.
All right, so how do we fix it? How do we break down these siloed walls?
Well, I think everyone in this room would agree. I don't think anyone purposefully designed a system this way. I don't think anyone set out to industrialize the care delivery experience. But we have an opportunity right now not to sprinkle AI over all of these workflows and hope things are just going to get better naturally. In fact, it could get a lot worse. AI versus AI, agents versus agents. That's probably a race to some dystopic future nobody wants to live in. Our opportunity right now is to use AI to actually rethink the system, redesign the system. Can we compress workflows? Can we let agents attend the lunch and learn about compliant documentation so I don't have to? Can we let AI figure out how to get all that clerical work done so I can spend more time with my patient? And what if we can shift as many of those workflows upstream? Whether it's a care gap, whether it's a quality measure, whether it's a clinical trial, instead of days, weeks, months later, what if we could shift them into the background upstream? What if we could connect not just clinicians and patients, what if we could connect providers, payers, and life sciences in a way that actually improved experiences and improved outcomes? And the wild thing about this moment right now, and I think this room makes it clear, it's possible. The people, we're all coming together around this.
Right, we've literally got everyone in the room here. So let's connect the dots, right? Providers, payers, life sciences, all coming together, shifting it left. You're talking about the moment of care, really.
Yep.
And you've anchored Abridge on the conversation that, like we're having here from the very beginning. So why'd you do that, and how does that set us up to solve the bigger problem?
Yeah, it's been one thesis for us all along that healthcare is human. And when you think about it, the most human signal out there, it's a conversation. That moment, just like this moment, that moment between the clinician and the patient is where we think you can bend the trajectory on experiences, on outcomes, on costs. And if you think about all of the information and learning across all the different systems, and if you can surface all of that information at the right time, in the right context, at the right moment of care, we think you can change everything.
And the thesis has worked, right? We've crossed some thresholds that are pretty humbling.
Yeah, we are incredibly privileged. We are partnering with well over 300 health systems. In the next 12 months, we will touch well over 100 million patient-doctor encounters. And we're receiving some multiple of 100 million user edits, bits of feedback that actually help us improve our models, help us deliver a better product. I'm excited, incredibly privileged today to announce that Northwestern Medicine, one of the leading academic centers in the country, is also now using Abridge enterprise-wide.
So welcome, Northwestern. So we're giving time back to all of those doctors and nurses and therapists and clinicians of every kind. And we want to take a minute here to show you a little bit of the scale and what it means to people.
Full day of 22 patients, out by 4:30 p.m., notes done. That's nice.
When I think about Abridge, I think the thing that comes to mind is it's really a cornerstone of how I practice medicine today. There's just no way I would do a clinic or see a patient without using.
I can be present throughout my clinical encounters. I don't have to think about, oh wait, did I get that? Do I need to write that down? Because I know Abridge has my back and has everything ready for me.
Abridge makes me feel free because I can really look at a patient, really listen, and not have to be thinking about what do I need to put in the computer.
Full day of 22 patients, out by 4:30 p.m.
I don't have so much way down with my patients.
For us, those aren't installations, those aren't integrations. That's a map of trust. And when you think about it in healthcare, the only currency that matters is trust. Healthcare moves at the speed of trust.
We talk about trust all the time at Abridge, and of course the conversation. So the conversation, the scale, the trust, this has kind of given us the opportunity to bring it all together. So let's now describe the core problem that we want to address from your perspective as a clinician.
Yeah, so I was rounding in the hospital a few weekends ago, and I see a patient, and I'm taking their history, and then I write a note, and then I put in diagnoses. They map to codes. Those codes end up informing a claim. That claim ends up getting cleaned up by some expert in my health system. It goes to eventually the insurance company, who's going to edit and adjust it even further, and they're going to decide whether to approve or deny. If they deny, it comes all the way back to that expert in my health system, and then they're going to get the nerve to send me an email message asking me if I can write an addendum, an adjustment, or actually just bring that patient back because there's no other way we're going to get paid or no other way we're going to get that patient the care that they need. Now think about that same workflow. Think about shifting left. Think about compressing a 12-step process into a 2 or 3 or 1-step process. Maybe it could be related to a quality measure. Maybe it's related to a care gap. Maybe it's related to a clinical trial. But so many of our processes are late and they're lossy. And we have an opportunity right now to compress, to make them more prospective, to make them more real-time.
So the big question to me then is you talk about all these workflows that are messy. Where do we start? Like, how do we decide what to build? There's so much to build.
We have a refrain in our company that feedback is oxygen. And there is so much to build. And it's our health system partners. It's our users. It's our clinicians. They're the ones who are telling us what to build and in what order. So maybe we can play a video.
There's nothing worse than seeing a patient in the clinic and the patient has questions or you have a nagging feeling that you're missing something in your differential diagnosis and you have to log out and log into another application or leave the room to get the necessary resources or answer the question that you'd like to answer before the patient leaves.
I think what clinicians want is supportive evidence and guidance that takes into account the context in which that question is being asked.
As medicine has advanced, care has become more complex and dependent on large clinical teams that span the ambulatory, ED, and inpatient spaces. These dedicated teams of nurses, physicians, and pharmacists need to share the same patient story.
The biggest issues with care coordination can happen at the transitions of care.
We ask physicians to deliver perfect care. Then we fail them on the paperwork. Millions of dollars in legitimate reimbursement walk out the door every year, not because that care wasn't delivered, because the documentation did not tell the full story.
We also carry a really significant cognitive burden and mental load when it comes to meeting all the other requirements, from documentation to clinical documentation integrity.
I'm going to let you in on a little secret about med school. We didn't take any classes on insurance or on prior authorization or on billing or on compliance. That's truly not why we went to medical school. We went to medical school to learn how to care for patients, to support our communities, and to advance the science of healthcare.
All right, so here we go. We've heard from the people that matter most to us in terms of the feedback loop that we get. Shiv, go for it. Tell us about the new Abridge.
Clinician intelligence platform, bringing it all together. On the product side, features relevant to compliance, relevant to billing, all the way to features that are focused on clinical intelligence and decision support. Today, we're announcing partnerships with the American Heart Association. We're announcing partnerships with AHIMA, AAFP, ADA, the Journal of Oncology, the Journal of Neurology. Later today, we're gonna have panels with leaders from Aetna, leaders from Cigna. And we've got a really, really big announcement that I know that you and I have been talking about.
We're pretty excited about it, yeah. So why don't you let folks know this is a big deal?
Yeah, I'm excited to announce that Eli Lilly and Company is making a strategic investment in Abridge to support evidence-based care and research access at all the moments of care.
Pretty exciting. And all that in a new UI too, which you'll see soon when we get to the demo. So here we are. Providers, payers, life sciences, connected through a single source of trust. Paint the picture, what happens when it all comes together.
I mean, I can imagine myself. Imagine every single clinician out there rounding the hospital right now, feeling like technology, like Abridge, has their back. Feeling like there's a team of residents, a team of assistants, a team of agents that is figuring out all the things that they want to know about, helping them feel like superheroes, helping them ask the right question, leverage the right evidence, create the most clinically useful and compliant note with all the right diagnosis codes, and imagine it works at every single moment of care across all the different care settings.
All right, so I'm sure you're all getting excited to see it, and we want to give all of you a little context, give you a little feel how it will play out in context. So we're going to show and tell. We're going to take you through some scenarios. Shiv's going to break it all down for you. But before we do that, I just want to put Shiv on the spot a little bit. I know we both think about our dads up here, and you talked about your dad at a company all hands we had last week. So I'm going to just ask you to get a little personal and tell everyone what it means for you.
Yeah. So my dad is 82 years old. He was a cardiologist. He retired some time ago. He retired because he couldn't type fast enough. He has heart failure. He has triple vessel disease. He had a STEMI a few years ago. I get to see him every Sunday. I get to see my kids see him every Sunday. I now commute from Pittsburgh to San Francisco every Monday morning so that I can see him every Sunday. Those Sundays are sacred. More than anything else, I want to be able to say that we were a part of a team that fixed this. And it's going to take all of us to actually do what we just described. It's going to take everybody in this room to figure it out, but this is the moment.
For sure. Everybody in this room, everybody watching, everybody at those 300 health systems, 100 million conversations a year, providers, payers, life sciences, connected for the first time around the patient. It's really is for all of us and for everyone who cares about healthcare, which of course is all of us. So Shiv's gonna take it from here. He's gonna show you exactly what all of that looks like in the life of one patient. Thanks for the conversation.
Thanks, Jonathan. So you think about it. Our thesis is that healthcare is about people, they're having conversations. If it's about conversations, then really the wildest demo that we could ever do for you would be two people just sitting there and talking. And that's it. Because the technology is doing everything in the background. But before we show you how it all comes together, we want to unpack all that would need to happen in the background to pull this off across all the different settings, inpatient and outpatient, for example. We want to talk about those settings explicitly because the workflows are different, the challenges are different, and because there are so many special opportunities across care settings to connect the dots in a way that benefits the patient ultimately. And then, after we kind of go through those stories, after we unpack what happens in the background, we're going to show you how it all comes together in what we think is a deceptively simple experience. So first, we're going to see what this can look like or what needs to happen in the background in the inpatient care setting. And one thing about all the different care settings is nurses are the scaffolding of healthcare. I could not function in the hospital without them. Really, nobody could function in the hospital without them. Patients couldn't get their care without them. Care coordination is a huge challenge. It's a huge opportunity. So I'm now joined by Alyssa, a registered nurse who runs clinical success for us at Abridge, and Rhiannon Frederick, System Chief Nursing Officer at the Mayo Clinic. Let's play out that scenario in the inpatient setting.
Hi, Alyssa. My name's Rhiannon. I'm your nurse today. I hear you've been having some problems breathing. Can you tell me what's going on?
Yeah, I've really struggled to catch my breath over the last couple of weeks, and I've noticed that my legs are really swelling. My husband finally made me come in tonight when he noticed that I couldn't even make it to the mailbox without stopping to catch my breath.
Goodness, it sounds like you're having a rough time. You're in great hands with us. I see you take quite a few medications. How's it going with those medications?
You know, I'm trying. I'm doing the best I can. The new heart failure one that they put me on a few months ago is honestly just a little bit too expensive. I haven't been able to start that one because I just can't afford it right now.
I get it. Sometimes you have to make hard decisions when you're managing your finances. I'll just take note of that and then let the care team know to see what we can help figure out for you. Okay. I'm gonna go check in with the rest of the team and we'll be back in to see you really shortly, okay?
Okay, thank you.
Okay, so now let's play out what happens when the doctor, this happens to me all the time, when the doctor on the team approaches the patient room. My colleague Matt, clinical strategy principal at Abridge and a PA by background, will walk us through his workflow with Abridge.
So to start, I might ask Abridge to generate my pre-admission note. Before I walk in the room, it's going to help me prep for the admit I'm about to have. In the background, it's going to take all the context from the EHR, that ED clinician's note, the documentation from Rhiannon, and it's going to give me a summary and discussion topics so I'm best prepared. In the summary, it might say that Alyssa has a history of heart failure. She's got an EF of 30%. She was admitted from the ED about 2 hours ago. There's a note here about a medication access barrier. She's been unable to fill Entresto. She's not on GDMT. There's no SGLT2 inhibitor. And she's got an A1C of 8.2. So these discussion topics look good. Everything's in place. But I might want to ask a clinical question right now. And I might do that by tapping Abridge AI, and I might say, given that this patient has an ejection fraction of 30% in the current regimen, is an ARNI initiation indicated during this admission? Should I be starting an SGLT2 inhibitor? Good. I should optimize GDMT. I'll make sure she gets the coverage she needs, and I'll add that to my discussion topics.
Okay, this is another good moment to sort of break the fourth wall. A team of agents is working for Matt behind the scenes. They're working in parallel to basically read prior notes, read prior labs and procedures. This team of agents is looking at nursing assessments. It's extracting diagnoses from prior notes that were written. It's reconciling those diagnoses against payer medical necessity, and then reviewing system-specific diagnosis ontologies, and then it's applying intelligence in a very specific way. There's no alerts, there's no pop-ups. It's showing up as discussion topics. And all those discussion topics, all those summaries are really shaped by the patient-specific situation. Now, Matt also invoked clinical intelligence and decision support. He asked a specific question in the hallway before he walked in the room. And that's just a glimpse of what clinicians are doing across the country today. Clinicians can get decision support shaped by all the context that Abridge can glean about the patient. It's not just pulling maybe medical data, it's also pulling evidence and system-level pathways, including from UpToDate, from New England Journal of Medicine, from JAMA, from AHA, we just talked about, AAFP, and so many more. Clinicians can feel fully prepared to work through the most complicated inpatient scenarios that way. So thanks, Matt. Let's keep moving.
Alyssa, it's great to meet you. My name is Matt Troop. I'm from the hospitalist team here. I was reading through the nursing notes and just wanted to hear a little bit more about how you're feeling.
Yeah, so really just struggling to breathe, even doing routine chores around the house now. My legs have really been swelling, and the last couple of nights I've actually had to sleep propped up on 3 or 4 pillows just so that I could breathe through the night.
I heard from the nurse that there was a medication that the cardiologist started you on in the outpatient setting, but there's been some trouble filling it. Tell me more about that.
Yeah, it's honestly just too expensive for me right now. They told me that I could stop all of my previous medications when I started this new one, but because I couldn't afford it, I've just been taking my lisinopril, assuming that has me covered for now.
And you mentioned some of the symptoms you've been having. Have you had any weight gain in the last couple days?
Yeah, you know, over the last week or two, I have gained about 8 to 10 pounds, which is pretty unusual for me.
Okay. And tell me, are you still smoking?
I am. I'm trying to cut back. I'm down to about half a pack a day now. I did try the patches last year for a couple of months, and they were actually helpful.
Got it. So in addition to that new medication that cardiologist started, we're going to restart that for you in the hospital. There's this other medication called Jardiance, and it's going to help with your heart function as well, and it's going to get you on all the medications necessary for the best outcome. I'm also going to work with the pharmacy and social work teams to make sure everything's covered. Does that sound okay?
That sounds great. Thank you.
And one more thing, you know, your blood sugars have been trending higher despite the metformin. That Jardiance medication that you take can help lower the blood sugars as well. But I wanted to ask, have you had any numbness or tingling in your feet lately?
You know, I have had some numbness and tingling. It's definitely worse at night, so I figured it's just from being on my feet all day.
Okay. You know, over time with high blood sugars, it is possible that you get a little bit of nerve damage, something we call diabetic peripheral neuropathy. I'll make a note of that. We'll also, again, start you on that Jardiance, and we'll see how things go.
That sounds great. I just don't want to end up in the hospital again.
Of course. I'll see you again in the morning, Alyssa.
Thank you.
Thank you so much, Matt and Alyssa. So documentation integrity in the inpatient space. How do we think about that? So during the visit, what you just saw, the focus was the patient. After the visit, Matt should be able to hit stop, swivel his chair. His note should be there when he has time to review it. But what does it take to actually pull this off in the hospital? So first, the note. Inpatient notes, as we all know, are just different. Beyond the clinical aspects of a note, no clinician was trained to write perfectly compliant notes for every single quality measure or sort of revenue cycle rule. It's just impossible to keep track of all the latest rules around how to code at the right degree of specificity and accurate in an auditable way. But we've trained our models to do that work for Matt behind the scenes. So when a visit's complete, our query engine shifts everything left. Abridge will detect a gap. That's a low latency model that's working behind the scenes to detect those documentation gaps. And then there's another model. It's around query generation. So when a gap is found, it's generating basically a query, and all those queries are based on AHIMA guidelines. Now, when the documentation is right the first time, we know that queries and denials will drop. You think about the highest quality notes. Shipping notes is very, very high stakes. This is a high trust environment. We need to have the highest level of science and rigor. The failure modes are very real and they're very measurable. Misspelling a name of a medication, for example, that can become a bad order. Diarization, who said what, is a big challenge because that can impact billing and compliance. We've created several in-house models to ensure that quality. So first, we have our own in-house speech recognition models. They're medically tuned, they transcribed real conversations accurately, and they attribute who said what, and they can work in a really noisy hospital environment, like an emergency department. Second, we have an in-house model that generates distinct sections of a clinical note, trained on millions of encounters at this point in time. Now, right now, 70% of our notes have sections that are generated by an in-house model. Now, there is a refrain right now in tech. that evals are the operating system. So how do we know that this is actually working? Our endeavor is the highest quality note across every single specialty setting. And when we think about the life cycle of shipping this type of technology, we think about what happens before we even ship. You can't ship a party trick. What happens before? We have to measure. So when we think about measurements, we think about LLM judges, for example, that can measure accuracy, completeness, compliance, style, and organization. We also think about how we've got thousands of board-certified clinicians right now who check our work and calibrate those judges. When we say for clinicians by clinicians, that's partly what we mean. When we're ready to deploy because we've got the confidence, we stage the rollout to make sure it's responsible, and we A/B test all along the way. And then after we're deployed, we continuously monitor. And we're looking at subjective feedback. We're also looking at all the star ratings that we get, and we're continually improving with all of those edits that we get as well. And that's a treadmill that we'll never, ever get off of. Now, one last thing, I'm talking a lot. I want to talk about personalization. Beyond a compliant, billable, and accurate note, we want this to feel like your note as a clinician. Every single clinician out there documents differently. Once you've seen one, you've seen one. Personalization to us, it matters at 3 different levels. One is your organization, and that's honestly where we've focused a lot of our time over these last couple years. How can we hit the floor for all things related to compliance, related to billing, related to completeness for clinical communication? Then we think about your specialty. Every specialty has its own specific style, structure, and content preference. And that's, to us, that's the floor as well. But then there's the ceiling. What can we do to make this really feel like you? How you practice, whether it's your history of present illness, whether it's your assessment and plan, whatever those stylistic preferences happen to be, we can meet them right now. And you can see on the slide that we can train off of your recent notes to be able to get you there. So let's keep moving. And this is heading towards our real demo very, very soon. So we've got Alyssa again. And now she's in the outpatient setting. And she's gone home, she's stable. 10 days later, she's in her PCP's office. And we've got a clinician, Nadim Ilbawi, System Medical Director at Endeavor. That gap between discharge and outpatient, by the way, all of us know, is incredibly risky. And Nadim might ask Abridge to generate his pre-visit note so that he can sort of get a sense of who she is. And this time, surfacing all the context from that inpatient admission that we just saw. So again, these are agents in the background signaling only what matters for this patient in this visit. So Nadim, take it away.
Alyssa, hey, good to see you.
Hi.
How have you been since the hospital?
So much better. My breathing is night and day difference. The swelling in my legs is almost gone. And yeah, I'm feeling great overall.
Wonderful. That's so good to hear. I think your daughter's graduation's coming up, so the timing's really good, right?
Yeah, I'll actually be able to walk the bleachers now.
Excellent. And have you been taking all the medications from the hospital, including the new heart one?
I have. The program that the hospital set me up on has been incredibly helpful.
Good, okay, and that medicine, the Entresto, is really important for your heart. It's gonna help keep your heart stable, and wanna make sure you keep taking that, so I'm really glad the team was able to help you fill that. And how about the new one they started in the hospital, the Jardians?
Taking it every day.
Excellent. And that one's serving 2 purposes for you, Alyssa. It's helping lower your sugars and helping your heart stay really healthy. And speaking of, how have your sugars been looking at home?
Better. I've been using a continuous monitor, so they've been consistently in the 160s to 170s most days.
Okay, that's a big difference from the last time we met. And the Jardians is a big part of that. So let's keep the metformin going alongside it, and let's see where your A1C lands in a couple months.
Okay.
Tell me about the tobacco use. Have you been able to quit smoking?
Almost. I'm doing so much better. I'm down to 1 to 2 a day. The new medication that the hospital started me on has really helped with that.
The Varenicline, right?
Yeah.
Excellent, good. I'm glad it's making a difference, so let's keep going with that. And then tell me about the tingling in your feet that you mentioned to the hospital team.
Yeah, that's still present. I actually think it's gotten worse, especially at nighttime.
Oh, I'm sorry to hear that. Yeah, and I reviewed the notes and the findings from the hospital, and I'm sure they shared this with you, but this is a condition called diabetic peripheral neuropathy. It's where some of the nerves are damaged by high blood sugars over a long period of time. So you and I are gonna work together to get your sugars to goal and to target, because that's the most important thing we can do to keep this from getting any worse.
Great.
All right, and there's one more thing I wanted to mention, Alyssa. There's a study running at our medical center right now for people with your type of heart failure. And based on your history, your ejection fraction, and the fact that you're now on full guideline-directed therapy, you could be a good candidate. Is that something that you'd be interested in?
Yes, that sounds like a great opportunity.
Excellent. Okay, so the referral's in. I'm going to have the research coordinator come and speak with you after we're done here. They'll walk you through the consent process and share some additional study details. And then let's plan on seeing each other in about 3 months for a follow-up.
Thank you so much.
You're welcome, absolutely.
Thanks so much, Alyssa and Nadim. So we just went through a visit. There were a lot of boxes on there. Hopefully you saw them, and for a reason. At the end of the day, everyone, payers and providers, want to know the full story of who this patient is at the highest level of specificity so that they can hopefully deliver all the resources to keep that patient healthy. And you remember the neuropathy finding from the inpatient stay? It was there. So built on the foundation of our CDI capabilities that we talked about, we created our own in-house model to go from diagnoses to ICD-10 codes in less than 600 milliseconds with high accuracy. That sort of latency is key to being workflow. We've achieved an 85% F1 score compared to 69%, from a technical standpoint with one of the latest, for one of the latest frontier models. And so that's a real delta. That's what it means, we think, to be a vertical AI company. We check fine-tuned signals from each of the meet criteria, what the clinician discussed monitoring, evaluating, assessing, or treating to ensure that the condition is fully addressed. And then finally, we collect transcription-level evidence for each of them for audit purposes. So I want to talk about a couple things before we kind of move on from here. We've talked a little bit about risk adjustment. Now let's talk about clinical trials. And we just unpacked that a little bit. We saw a clinical trial match based on this patient's history, as well as the available studies at that specific institution. So the right patient at the right moment, based on the conversation and the decisions that you're making today. So we're bringing together data that lives on top of multiple systems, from a clinical trial management system to a medical record system to maybe a payer, longitudinal, HCC-related medical system. We're reasoning against inclusion and exclusion criteria in this case, and only bringing up guidance when it makes sense for the patient. Okay, so we've done a lot of storytelling, and we just went through how Abridge can work across multiple settings. We gave you a sense of how much is going on under the hood. We unpacked all the parallel agents, the teams that are working for you. How do we make this all come together and feel, remember like what Ambient felt like in 2023 when it first came out? How do we make it feel like a product that anyone could use, that anyone could just pick up and start playing with? So let's show you how that all comes together.
Hey everyone, I'm Nathan, one of the group product managers here at Abridge.
And I'm Michał. I'm a cardiologist by background, and I've recently joined Abridge as a clinician scientist. And today, we're very excited to show you what the team has been working on. We've been building a solution that allows the physician to interact with Abridge directly by using their voice. And this works just by simply saying the activation phrase. Hi, Abridge. Can you help me finish the op note for Mr. Smith's TAVI?
The operative note draft for Mr. Smith is prepared. It's missing vascular access, prosthesis size, estimated blood loss, and complications.
Yes, so we've used right common femoral 14 French. The valve was Edwards SAPIEN 3 Ultra 26 millimeters. Blood loss was around 50 milliliters, and there were no complications.
Op note drafted. You can now review and send to EHR.
Excellent. Send to EHR.
Sent to EHR.
And voice is such a great way to interact with Abridge. It's not just for documentation. Michał can also use his voice to start a visit and ask a question in the middle of it.
Hi, Abridge. Let's start recording Nathan Chan's visit. So tell me, Nathan, how have you been feeling lately?
Not that great, honestly. Still kind of hard to breathe when I walk around.
And this shortness of breath, is it triggered by like a lot of exercise or it's moderate activity?
Like walking up the stairs.
Have you been taking all the medications that we have prescribed since the last visit?
Yes.
All right, let me look up some of your results and see what is there that we can do. Hi, Abridge. Is Nathan eligible for any clinical trials?
He may be eligible for the Abridge HF study. He remains symptomatic despite maximal therapy, and most screening criteria are already met. But an updated echocardiogram is needed to confirm his ejection fraction and complete eligibility assessment.
All right, please order that echo for him.
Done. Confirmatory echo ordered. Would you like me to notify the research coordinator?
Yes, please do that.
Done. Research coordinator note drafted.
When I'm done for the day, I can just ask Abridge, hey Abridge, can you prepare my charts for tomorrow? And Abridge is working for me. And this is the reason that I've joined Abridge, to create solutions like this for all physicians. Solutions that allow us to understand why we got into medicine in the first place.
So one interface, the Abridge AI agent, can help a cardiologist like me create an op note, get a patient one step closer to a life-saving clinical trial, or prep my charts for next Monday's clinic, all in under 3 minutes. Without Abridge AI, this would be hours of paperwork, as we all know, but instead, it's a conversation. In a world where AI can attempt almost any task, the most important question now is, what should it do, when should it do it, and with what guardrails? And that's where we try to hit different. We've put deep thought into defining the right jobs, the right context, the right tools, and the right actions. We're deploying teams of these specialized assistants for each of those jobs, and it's all happening in the background. For the opera note, for example, the agent's figuring out the most common procedures, variations, and templates. It's compiling a structured map of critical variables per procedure so the agent knows what complete actually means and when it makes sense to actually ask. For the clinical decision support feature that you saw, Abridge's search ranking in medical literature takes a wide variety of signals such as freshness, citation count, and the most relevant patient context. So putting it all together, what does it all mean? What does this all mean to me? It means that not being able to type fast enough isn't a limiting factor anymore. We can't wait for you to try this. I hope everyone here will go downstairs and visit our demo booths, but I want to first transition to our panels and show you how we're all coming together around this. Our first panel is called Bridging Providers and Payers for AI-Enabled Value-Based Care. We're excited to have Dr. Ben Kornitzer, Senior Vice President and Chief Medical Officer, Aetna, and Deanna Hanisch, Vice President and Chief Information Officer at Johns Hopkins Health System. Please join me in welcoming them to the stage. Thank you.
Hey, Shiv.
Thanks. All right, amazing. Hopefully you can see some of that, or hear some of it. You know about it. It's a really wild moment, right now. And I think that we've talked about this. We've never, I think, disagreed at the really high system level about the destination. When you think about value-based care, it's a very kumbaya story. Let's know the whole story about a patient, and let's figure out how to get them the resources to keep them healthy. And while that's been kumbaya, there's always been like tension around execution. And I'm curious if we can start there. What have we learned, over 20 years? And what do you think about this moment, in terms of the technology that's now at our fingertips that we can evoke with our voices? What do you think, the potential is for us to change things? Maybe.
I'll go first. And first of all, the fact that Deanna and I are here together, I think, is a demonstration of how much excitement there is to really capture the moment. I think over the past 20 years, quite honestly, the clinical evidence, the financial incentives haven't always been aligned in a way that can really make it easy to lever care when the physician is sitting across from a patient. And when there's that disconnect, either between the provider, the payer, the technology platform, patients feel that, and the experience of healthcare shows. I think what's unique today is the ability to stack our hands and bring that signal right in front of physicians at the moment of care. And so we've got a lot of work to do, but the level of enthusiasm that we have to create something different is really palpable and special.
Absolutely. I'll add on to what Ben said. At the base of it all, it's outcome-based, which we all agree to. It is information-driven, so it's sharing of the information from the providers back to the payers. But what it also has been is administratively burdensome. It is yet another quality measure to document. It's it's another level of specificity, and that's just pulling away from some of the conversation. I think one of the really unique things that Abridge has added for us, and really Scribes in general, is it's taken away some of the administrative burden. And if you can take away that administrative burden in this area as well, it gets back to what is really important, kind of raising the signal from all of the noise.
Yeah. Thinking about workflow and how we can get this done, how we can get into workflows in a way that doesn't feel like overhead. I'm curious, maybe Ben, if you can kick things off. How do you think getting into workflow is an opportunity to like reduce friction and help us get a better sense of who patients are?
Yeah, so again, coming from the payer perspective, our role is to make sure that all of our members get really amazing outcomes. What we don't have is the connection to that moment when a patient is sitting in front of their physician having to make really important decisions. One of the opportunities that I think is unique and differentiates, we all come with different points of data, right? So the provider has the data that's embedded in the EHR. We may have data from claims information, visits they had to other health systems, pharmacy data. The ability to pull that all together, to connect the dots at the point of care, and for the first time ever, not ask doctors to have more clicks and more burdens, because VBC has always meant more work, more documentation, but actually make it easier for them to do the right thing. I think patients will feel that, and it's something that we really care about and want to invest in.
Yeah, you're bringing up such an interesting concept that I think is also a part of the AI zeitgeist right now. It's this idea of context engineering. And in healthcare, the context around any given person might be very fragmented. It might live across any number of different systems. And I think you're pointing out right now that the context around maybe their longitudinal disease history, it might live in disparate systems. And it's easier said than done to find a way to stitch all of that together. And Deanna, you understand the technical sort of underpinnings of our system incredibly well, as much as you do workflow. And I'm curious, as you think, to the past any number of years, what has made it so difficult, technically, to actually execute?
Yeah, absolutely. I mean, first it's starting by getting all of the information, but that information is almost overwhelming at this point. And now it's trying to get that information down to what is meaningful and useful. We have people prepping charts to help make sure that when it gets to the physician, it's not just noise. Otherwise, you're pushing so much up to them. And so it's trying to think about how do we use that information, but really pull what is relevant, what is important out, rather than kind of just all of the volume, because our data isn't the same. The claims data looks nothing like the EHR data that we have. And how do you really stitch that together? How do you pre-close the care gaps? Rather than chart chasing it down, so we don't ask the thing that the patient's already gotten done. And Ben knows because it's in his claims data, but we don't know because it wasn't done in our system yet, or maybe outside of our vast networks of interoperability. And I think there's a lot of opportunity, if we do it right, to really abstract it down to not adding more burden, but really starting to reduce to what's really needed.
Yeah, I think about some of the stories that we were telling earlier. I'm in a primary care clinic and I'm seeing a patient and they have diabetes, but somewhere else in the record is a history of end-stage renal disease. And I need to get through, and I'm just gonna write my note as fast as I possibly can, or use technology that maybe is just listening and not really stitching together the longitudinal story of this patient. And so that might mean that the end result note just says diabetes or heart failure unspecified, something else that is the bane of everyone's existence who's trying to figure out how to make one of these models work. And so I'm curious, Ben, how do you feel about a technology that, even if it's not necessarily sharing all of this context, the data is not fully liquid, it's not just flowing back and forth, but we have this opportunity right now to figure out how to connect the dots across all this context. How do you feel about that idea? And do you think that there's a world where all the retrospective analytics that happen right now in VBC could shift left, could become perspective?
Yeah, nothing would make me more excited. I mean, we actually talked about the fact that literally the name Abridge is a bridge, right? Connecting people across the healthcare ecosystem. Right now, about 25% of patients with CKD don't even know they have the diagnosis. Large numbers of patients with diabetes don't even know they actually have the diagnosis. And so our ability to get upstream, as a physician, right, I always have the patient at the center of everything I do. And so I think this is such a unique moment, rather than create an arms race and industrialize the parts of healthcare that frustrate all of us, to actually stack hands and say, what can we do that's better for the patients? And that's going to be a huge win for Deanna and I, providers, payers, but most of all, it's going to be a huge win for our patients.
Totally. It's interesting to dwell on this moment right now, because I think we are at an inflection point. And what happens if we don't figure this out? Like, can you, like, I guess, wax poetic a little bit on that?
Go ahead, Deanna.
I'll start. It gets harder. It gets harder as a provider. I admire our PCPs so much. Their job is incredibly challenging to stitch together the complexity of the world. And at the end of the day, they care about those patients sitting in front of them. It's not just a number, it's not just a code, it is a person that they have been taking care of for years or decades. And I think one of the things that all of this does is has added more and more administrative burden, and more bots against bots is what we're all fearing. Yeah. And I think the idea that we could do something to make their job easier, just like we have started to do, is really the opportunity out there.
I think what's going to result in is healthier Americans, people enjoying their lives, grandparents going to their kids' graduation, dancing at their grandkids' weddings, and doing it in a way that reduces all the fragmentation that we see in healthcare and the challenge of experienced healthcare right now.
Yeah. Really quick, rapid fire. Single question. Let's say you close your eyes and you can have a team of AI agents do anything for you. What's the top couple things that you would want?
Sure. I would want a system that can look across all those disparate data sources and actually begin to weave that story together. 2, I'd want them to be able to surface it at the point of care in a way that's actionable. And 3rd, I wanted to find a way to really engage people in their healthcare. I want Americans to be owners of their own healthcare destinies.
I think you said it well. I'll add to it. I want the agent to be a part of the care team. I want them to help do exactly what you said, but bring it all the way back to the patient instructions to really distill down what happened in that encounter and those conversations, and then bring it back to where it really matters to that patient at the end of the day, and then to continue to help to follow up once it's outside of that 15 minutes.
I love it. I think I would want more time with you, and I would want to figure out if an agent can figure out this business model and really make this such a slam dunk win-win opportunity for all of us. So what's exciting though is it feels like it is, and it feels like this technology is creating that moment. So I just want to thank you both so much. Thank you for being here, and thank you for being a part of this.
Thank you.
Thank you. Really appreciate it. Thank you.
These are memories we can remember down the road. I don't want her to remember Dad was always gone, Dad was always writing notes, Dad was always at the hospital. You need that downtime. You can't do this job all day long, every day. Being able to be an urgent care provider in the hometown where you live is amazing. You see people before, during, and after their problems, and the talk about you around town is hopefully always good. I would typically stay several hours after work. We get out at 9 o'clock, I'd be here till 1 a.m. Then I would be back the next day. My first day off, I'd spend 8 to 10 hours writing notes away from family. I literally saw 52 patients in 12 hours. I was on the brink actually of being burned out. One of the biggest things is my families used to take vacations without me because I had to write notes and stay home or join them later in the weekend. It quite frankly got to the point where I was missing my daughter's sporting events and stuff like that, and that just tore the heart. I needed to be there for my daughter. She's only a kid once. All right, I'll be back, okay? Thank you. All right, no problem. The Abridge platform has really opened up the ability to do everything real time. We don't have to worry about the notes. This is doing medicine, getting people feeling better, and I don't have anything to worry about when I go home. I actually get to see my daughter more because of the Abridge platform. How was your day? Good. She is an active dancer. She partakes in about 8 to 9 dance classes during the week, and now I can be there to help support that. Dad's off today. That means Dad's home. As soon as Abridge went into play, I was able to enjoy the job again. We always have this ongoing internal joke that, this job would be great if we didn't have to write notes. Thanks to Abridge, we don't write notes anymore, right? It does it for us. We review and sign them off. But quite frankly, the technology is amazing. It's helped us so much.
So for our final panel, I'm privileged to invite Kimberly Powell, Vice President Healthcare from NVIDIA, and we're going to discuss the first clinical conversation foundation model. Kimberly. Thank you.
Good to see you. It's such a great honor to be here and celebrate this amazing day.
So incredible to have you here. It's a privilege.
Thank you so much. It's really, really an honor. Can't take my breath away with every story and every vision that everyone in this room has had and everyone that you've featured.
Well, there's so much to talk about.
Yes.
So little time, and we want to cover a lot. Maybe it's a good place to start with just our announcement today. We announced earlier today a lot of really exciting work that we've been up to for some time now around building a clinical conversation foundation model. And for us, why that is so incredibly important and critical is that, Madhu just made that comment. You want to sprinkle intelligence everywhere.
Right.
And how do you figure out how to do that? How do you figure out also how to deliver the right level of accuracy, the right level of latency? You end up needing a little bit more control in spots than you might have anticipated. And we've been incredibly privileged to partner together and to build on top of the Nemotron model family. And we're incredibly grateful for all that you've leaned in on. So I'm curious, maybe to start things off, Kimberly, why does NVIDIA care so much about healthcare and the set of problems that we focus on?
Yeah, I mean, this goes back almost 20 years. I've been telling people I've been at the company about 18, where actually, Jensen, our CEO, had an encounter with radiologists early on who were trying to use gaming chips to do really hard math to do image reconstruction. And it was just at that moment that we knew we created something, accelerated computing and now artificial intelligence, that was going to be really helpful for some of the world's hardest problems. And we have done nothing but invest since. We're at this incredible moment in time, and we've felt for a long time healthcare will be one of the largest technology industries, and you're the antithesis and a complete example of how that is becoming complete reality. And it was also at the middle of, call it the 2015, it became very clear that intelligence is domain specific. And we're in this phase of AI where it's moving so fast. How do we make it our mission statement in the healthcare practice to make technology that moves so fast accessible to the healthcare industry? Mm-hmm. And so just take a minute and talk about what's happened in AI in the last, 18 months. Yeah. We went from AI that can generate things, AI that can reason, to AI that can do work. So we've gone through 3 huge technological breakthroughs in just the last, call it 18 months. And what we're talking about in our announcement is, you think about every technological breakthrough requires you to look at the full stack. Mm-hmm. We think of AI as not a model. It's a full stack computing problem. It starts with energy. It's then chips and systems. It's then AI data centers and clouds. Then it's core foundation models, and finally it's the application layer, which you squarely have put forward. That vertical AI application layer has incredible value, effectiveness, and an ability to change an industry forever. And so I think what we're recognizing together, and you've obviously come to this conclusion yourself, is it's time to go deeper in the stack. And so a clinical conversation foundation model, so that the complexity of healthcare and all of the workflows and the connectivity of this amazing ecosystem that you've brought to bear can be realized, because it has to become much, much more domain specific.
Yeah, I love it. Maybe just to sort of unpack that a little bit more, specifically your philosophy on open models, on the stack. I'm curious if you can unpack that, and I can certainly share how we think about things.
Yeah, that's right. It goes into this idea that imagine you try to throw a generic AI model into healthcare. It doesn't understand the clinical language. It doesn't have the clinical reasoning, and it surely doesn't have the domain expertise of all of the long-running tasks and interconnected work that has to happen for workflows to be completely transformed. And so if that is the case, that generic AI is just not going to work, we recognized this long ago when we started investing in an open model strategy, so that it could be a professor at a university, it could be a clinician who has this amazing unlock that they could imagine, has a well-invested platform starting point of open language models. We work on open models for biology. We work on open models for World Foundation models so that we can help realize robotics and automation in the physical world. And we give that to developers and application makers all over the world across every industry to realize this great potential and to go down more domain specialized application spaces where the real value is delivered. And you put the power of AI in the hands of the domain experts who can be extremely thoughtful in, one, making sure it's built so that it can be trusted, making sure it's built that it has traceability, auditability, it has all of the built-in knowledge of some very exquisite domains. How could any generic AI company do that? But our role we can play in that is by giving you a huge foundation to stand on of open models and then start to domain adapt them for these really complex workflows that you're going to build.
Yeah. When we think about workflows and we think about our product, really, from our standpoint, we just have to deliver the best possible experience. We have to be able to move all the needles that we were talking about earlier today. And to an extent, for sure, it means that we are going to partner with the frontier model companies, and we do. We have incredible relationships there. And also, since we have a very, a maximalist sort of attitude around sprinkling intelligence everywhere we possibly can, it means we do have to reach down lower into the stack and control our destiny. And latency is a big issue for us because we do want the clinician to be able to stop, swivel the chair, and have all of those artifacts there. And that's where this partnership for us has really opened our eyes to all that we can do. Even over the last several sort of training runs, what we've already been able to see, for example, F1 scores related to that CDI product and being able to predict the right ICDs have gone from, I think, 69% to 85%. And there's a significant delta compared to anything that we could get off the shelf. Similarly, with a separate type of model that tries to infer the context of the specialist, so it understands that I'm the cardiologist, and thus off the bat, the cardiology specialty-specific note should look a little bit different. We're raising that floor, so there's a lot less uncertainty in terms of what we need to do above it to make sure that the output sort of meets the mark. We're seeing similar results.
This is the second part of why open models are so incredibly important. We want to help you create the experience through all these very complex workflows that is, it's behind the scenes, it's very fast, it's second nature. It's just somebody working on your behalf. And so optimization, if you think about we have Nemotron, our open models going from 2 to 3, you're seeing 5 times the performance because we're taking a full stack approach on these models. They're at the frontier from their capabilities, and then we understand the technology today, and it will be ready for Vera Rubin, which is coming out next, which has a whole other gigantic leap in terms of latency as well as cost performance. So we think about, we want this capability to be abundant throughout healthcare, providing the right information, doing work behind the scenes, taking away the administrative burden. We want it to be accessible to every clinician treating any patient. And so that means we have to be thoughtful about the token economics. And so every day we wake up in the morning as an accelerated computing platform to think about not only the model, but these complex agents and multitask, long-running tasks, always running agents, right, who are going to do something I'm super excited about in the future, which is, think about hearing something in that conversation as a preventative measure. Even because it's always running and it heard that thing and it associates this across a whole bunch of other data points. And we're going to start to get into hopefully much, much earlier detection even. But that requires that these agents are running around the clock. And so we've got to be very, very thoughtful about the token economics. And that is, again, giving amazing applications and platforms like yourself the ability to control all of that.
Yeah. We are in year one of what will absolutely be for us a multi-year investment. And already we've found a way to collaborate, and it's very humbling for us, obviously. NVIDIA is NVIDIA. And our science team, being able to spend time, with your researchers, but also our product team, over time being able to surface up, like, what are the requirements? What do we actually need to do in order to serve all of our health system partners? Can you speak a little bit to how the partnership works, what the mechanics are from your side?
Yeah, I mean, it's been just an amazing two-way partnership. NVIDIA is not a healthcare company. We will never be. We never intend to be. But in order for us to tackle some of the hardest work in the world, work that has huge impact, and we convince ourselves we do have a unique ability to contribute, and we find a company or a thought leader or a CEO or your team who sees the future differently and understand technology is going to be an absolute core component. I mean, you talk about the platform, it's AI native. That is where two companies coming together, we've been working on speech research together. We've been, working and allowing you to train all these already domain specialized models that has allowed for your platform to be so widely adopted, and the joy and everything that you've brought back to the clinical practice and the patient outcomes, and become this trusted provider across the ecosystem. So we're working on everything from research to that hardcore engineering, so that things are running really fast and that the cost control is there, to now we're on this amazing new endeavor. You've called it a treadmill. NVIDIA often calls it the data flywheel. Because you've been able to scale at such a pace, and because you are so thoughtful in collecting all of the good feedback as well as negative feedback or corrective feedback to the system, this is all intelligence. You need the good, bad, and the ugly so that you can build it back into the system, and it becomes incredibly smarter. And once you have a foundation model like that, it becomes a core building block to then go make all of these downstream processes that much more accurate and effective in the work that needs to get done. And so it's been a pleasure. You've pushed us on our roadmap. We push you on your roadmap. And I think this is, it's such an honor to be included in the process. And we wake up every single day, and because your application, your platform is it's in my doctor's office. As a person who lives lower in the stack in technology, it's so motivating and just such an honor to be a part of it. And we're excited about the next couple of years together. This is a time the healthcare industry has never experienced in history, and you're making it happen, Shiv, and your team.
Thank you so much, Kimberly. Really, everyone, all of us are doing it together. So grateful to you, so grateful for our partnership. Thank you so much for being here.
Thank you, Shiv. Thank you all.
Thank you. Thank you.